So today's session is going to be on the Advanced Cancer Patient Research Navigator. And the genesis of this is that we have wanted to scale the work that we've been doing in the hackathons. There have been 3 now, 4, depending on how you count, and then the Prostate Cancer Lab, which currently has 7 patients. And we want to scale it to grow the size of the community, to grow the number of patients. We had a goal, looks very ambitious now, to find 100 patients by the end of the year. And so what I'm going to be reviewing with you is a pitch deck for this venture, which is, again, scaling up the things we've been doing, providing services for testing and treatment decisions, treatment strategy, and other services for advanced cancer patients. The goal that I have in presenting this today is that hopefully all of you will give me great feedback to make this better. The target audiences are to attract more patients. So there are multiple stakeholders, as there always are in healthcare. We've got the patients, which we'd like to grow. We've got funders who might provide grants to us. So this could be pharmaceutical companies, could be patient foundations like the Prostate Cancer Foundation, could be other philanthropies. We have physicians and researchers we want to attract. We have clinicians we want to attract, and people in diagnostics, molecular biologists, bioinformaticians, and so on. So there's a whole set of different stakeholders we want to attract to this effort that we have, which has a flavor of being community and being open source. So our philosophy is, where possible, make things free for everyone so that everyone can join, like a Wikipedia. Okay, so with that as background, any questions before I get started and go through? I'll try to go through the pitch deck in like 10 or 15 minutes and then get feedback and how we can make it better. But before I get started, any questions or comments? Okay. I'll do share screen, boom. Hopefully the technology will enable. Can you all see my screen? Somebody give me a thumbs up or a nod. There we go. Okay, thank you.
But go to presentation view, to make it a little bigger if you can.
All right. Let's see, is that, I'm looking.
Probably view up at the top.
View?
Probably.
Slideshow, try that.
Yeah, perfect. That'll work.
Loading. Okay, does that do it?
Yep.
Cool.
Yes.
All right. So I said there are multiple stakeholders, but I tend to start with patients. And so that's an array of patients across the top. These are Stephen Aldrich, Bryce Olson, Linnea Olson, people that have Casey Altman, Shirley Pepke. These are all people for whom we've run hackathons and that sort of have in mind as we're trying to offer these ideas and services and help. Many of those people have passed, so we're sort of doing it in their honor as well. The title, Advanced Cancer Patient Research Navigator, every one of those words has meaning. We're talking about advanced cancer patients, meaning those who are beyond the standard of care, who are metastatic, who are advanced. I always like the word advanced because it also means they're advanced. Like I like to think they're like advanced people, like smart. It's about patients, it's about cancer. It's not all diseases. It's about patients, patient-focused, those who are researching for the disease, and researchers coming the other way, doing research, and navigator, meaning that it has to do with finding your way and being a guide. The subline here is helping advanced cancer patients and their caregivers. Don't want to forget the, many people in cases like parents taking care of kids or family members who are taking the lead on the care for their friends or family, as Ken was mentioning. And the focus largely is on complex testing and treatment decisions, though we include everything. Like next week, the speaker is going to be on palliative care or you might be looking, we have future ones on finance or nutrition. And shop for services. So shop for services, meaning most patients don't shop. Most people don't shop when it comes to healthcare. They have a primary care provider, they have references or referrals they get to specialists, but they don't really shop. But we're thinking of this in terms of shopping and finding providers for a variety of services, sort of disaggregating what's usually all together in what you would get through your hospital or through your doctor or through your clinic. The companies across the bottom are those who have are collaborating and contributing to the development of this with an intention that we would add others. Cancer Commons, I hope everyone knows, again, Marty's on the line. He's the founder of Cancer Commons, which provides online second opinions for free, as well as runs virtual tumor boards, as well as works closely with XCures, which provides the infrastructure for the tumor boards, for the registry, and for access for patients. Cancer Hacker Lab is the group that I founded that's providing events like this and community building and the guide and these sorts of services. Prostate Cancer Lab, of course, is I co-founded with Rick Stanton and Brian McCluskey, and we have 7 patients who are at the core of Prostate Cancer Lab and a whole community, which I've got a slide for to describe that. Stanton Biosciences is Rick Stanton's business, where he's doing matching based on deep analysis of molecular biology. And then TGen, our colleague Nick Shork is, and a close friend of Rick's, has been actively involved in bringing their services to the table. They have a background in, on the research side, they're a research institute associated with the City of Hope. They do translation, it stands for translational genomics. So they're taking research and they're able to do complicated assays and tests and then interpret those tests and bring them to market. So those are kind of the founding partners that are developing this idea. I always like to start with a patient. I've got about a dozen slides, so hopefully, again, I'll get through them fairly quickly. Always like to start with the patient perspective. This is Brian's story. We could do Bryce's story. We could do any number of patient stories. But the main idea here is that he's been on a roller coaster with repeated decisions. It's not easy. And, you know, over time, there's some degradation of life. You don't like being on androgen deprivation for long periods of time and so on. And Brian is a former executive in marketing at Hewlett Packard, so he understands tech, he understands e-commerce, he understands personalization. And so he's always leaning into more tests, more data is better, more guidance for his treatment. So always trying to both get access to more testing as well as help that guide more novel treatment options and uncovering new treatment options through that testing. He's about to undergo a surgery where he's going to get more tissue for more testing so that he can do functional testing and just send the tissue all over the place to get more information to guide his treatment. He could have gotten radiation to attack his and remove and debulk some of his metastatic lesions, but he chose to do surgery in part because it'll give him tissue for more guidance. This is a nice slide which we use, which is just to make the point that these are for patients who are beyond the standard of care. When you look at the NCCN guidelines, they take you to a point. So in prostate cancer, if you aren't metastatic, you get a prostatectomy. If you're metastatic, you go immediately into androgen deprivation therapy, radiation, chemotherapy. It's all very prescribed. It's all very structured. And you get into unstructured land after you go through those lines of therapy in prostate cancer. There are other diseases where you end up in this zone of complex decision-making from the moment you're diagnosed. A pancreatic cancer, a glioblastoma diagnosis means you're very quickly in the zone of complex decision-making. And as it says at the bottom, no one knows the optimal way to treat any cancer. So there's no evidence, there's no easy answers, no one knows, and you know as well as anyone, and that's really an opportunity for patients to get involved to influence the course of their treatment. But it gets complicated because as soon as you get into this advanced cancer zone and where there aren't obvious decisions, almost everything tends to be off-label. Off-label means that it's the way that the drug was approved is not the way that you're going to be applying it. So you have a genetic mutation, EGFR or ALK, as Eric has. It's more typically seen in lung cancer. Therefore, the drugs are improved in lung cancer. Any application of an ALK drug for prostate cancer is going to be off-label. And then immediately, clinicians are concerned about off-label uses. We're also big proponents of combination therapies, drug combinations. Almost all those drug combinations have not gone through the randomized clinical trial process, particularly if you add dosing, because they're so personalized. There's so many combination options, they can't run randomized clinical trials for all of them. And so clinicians are concerned about toxicity, whether they can get reimbursement, liability, and we're looking into things like, is there a dosing strategy? Is there a way to do this that gives clinicians confidence to make these off-label decisions? Because advanced cancer patients can't wait for the clinical trials evidence, much as they'd like to, because those things take years, even a decade, and they have decisions to make in days, weeks, or months. This is a summary slide that shows the kinds of services that patients may be interested in. They are looking at education. Most people get this diagnosis out of the blue. They had no anticipation. When I was diagnosed with lymphoma, I didn't know what it meant. Like, what is lymphoma? I had no idea. So patients need to get educated. They need to find out about testing options, treatment strategy. They can search for a community of people who have gotten their disease and may be able to offer advice because they're further down the road. A repository for their data, for their tissue, so they can shop with not having to repeat the same questions and sources every time. And then there are personal services that people need for mental health, financial health, genetic counseling. And on the right here are, again, I introduced this on the title page, but here are the service organizations that have already come to the table to help with this, to help guide this. And we're also looking to add others. The obvious candidates for us are Massive Bio, which has been helping our patients find clinical trials, and CureMatch, which is an expert in creating drug combinations or finding and recommending drug combinations. Just to quickly, I'm a process guy, so this is the process description of the patient experience with the gives and gets. This is modified from something that Cancer Commons already does, but added a few little wrinkles. The idea that every patient would be getting a standard battery of tests, and those would include, for example, a blood test, hence the blood vial there. We would ask the patients to pay. The best way to align a service like this with the target audience patients is to have patients pay. We're also looking at other sources. The idea here is that patients would both give their data and donate it for others to see what the idea is that every patient is an experiment, and they have results and outcomes from those experiments, and they would then, whatever works and doesn't work for them would become resources for those who would follow. It would also mean that with their profile information publicly available, drug companies could come and say, hey, we've got a clinical trial we think would be just right for you. So it's a way to get lots of information for patients on the get side, advice on treatment options, guidance, and support for accessing treatments, and continuously being updated. So it's not a once and done thing, but as new tests become available, as new treatments become available, as the patient's situation evolves, which it does continuously, they would continuously get new ideas, new information. This is the value prop for physicians and researchers. So we would focus on this depending on the audience. The idea is that they can learn from patient experience. This is basically an argument for real world evidence. For those of you who know the distinction between that and randomized clinical trials. So that we would have all the patients contributing their data to this observational registry. We'd have a platform that would allow researchers to run experiments. There's a community, both for peers to sort of learn from, and also to identify patients with a specific profile. Again, pharmaceutical companies are always looking for patients that fit a specific profile to recruit to their clinical trials. And that's a win for patients too, if there's a fit with something that would help them. This is, again, just sort of breaking out the gives and gets. I won't spend a lot of time on this. For the physicians and researchers, this is what we would emphasize again if we had a physician and researcher audience. I think I've covered most of these points. This is our community. This is a continuously updated slide. Every time we have someone speak at one of our sessions, I add their mugshot. I just added Robert Nagorny, who was our presenter last week, for example. You see him over under diagnosticians and pathologists. He's a practicing MD. I could have put him over on clinicians, but his claim to fame is functional profiling. And so I put him over with the diagnosticians. But this is in a process flow with our goals are attracting patients. We currently have 7 who are in the middle. We then gather data through a standard battery of tests. We're very interested in things like whole genome sequencing, RNA sequencing, proteomics, and we're in discussions about interpreting those through the thirds, I guess, down at 7 o'clock on the circle, analyzing the data, finding treatment options. Just as an example, Rick and I spoke yesterday to Shepherd Therapeutics, which is doing transcriptomic interpretation, and we might be adding them to that group. And then our clinicians. And we encourage everyone to provide recommendations. If you have a treating oncologist you think might be interested in participating, the clinicians we have in our group basically are willing to answer email questions. They're sort of on call, and if we have a request to them, we can send them an email and usually we'll get a response. So we're always looking to grow all of the aspects in this community. And this is the basis that we are building on as we try to scale up. This is another perspective, like this is an internal look. What are the services that we provide? Again, I won't spend much time on this one, but you have patients coming in on the left. You have agents, both human and eventually AI, onboarding them. And then there's our education and services guide, access support, expert review, so a virtual tumor board in the community, analytics that's finding patterns and doing treatment matching, and the observational registry, which we mentioned, which Excelsior is the product that comes from XCures, and that patients would be contributing their medical history tests and their intent. And on the right, we have treatment options, experts, both approved drugs and clinical trials. Our model is that we have an ongoing deepening of relationship with the service providers. First of all, we identify service needs, and I have a working document that has over 30 services. And for each of them, we've identified service providers, as you would for a consumer's guide, as you would if you went to Amazon, any kind of search for services. And then for those that look promising, we invite the service provider to pitch their service at one of our Wednesday meetings, which again, many of you have probably seen that before. Then we have 1 or 2 of our patients try the service and report results. So to go with that Shepherd Therapeutics example, Rick is going to take his data, his RNA-seq data, and send it off to them and kick the tires and see what he thinks of their response. And then if it's good, we would potentially incorporate that service into our standard workflow and say, all the patients that come through our pipeline, you should get the Shepherd Therapeutics RNA-seq interpretation and see what biomarkers it identifies and what treatments they would recommend. And then number 5 here, continuously compare the service with others and swap. So the notion is this is a services architecture. For those of you who are technically inclined and have heard of services architectures before, this is the notion that it's a modular, componentized services architecture with what are called APIs that sort of define the boundaries of those services. And then we can plug and play. As ones that are come out are better, we will swap them in and out. So we like Tempus a lot, but Willie Hu says that Boston Gene is a better source for whole genome sequencing. And we might say, well, Tempus is our currently preferred provider, but we also like Boston Gene, and we might even steer things to Boston Gene as things evolve. And they will also be looking for service combinations across service providers so that we can put together bundles, whatever is right to help patients streamline their work. And that's another thing we'll be doing, of course, is trying to make it a one-stop shop and a once and done, so that once a patient is entered into our data and their medical history and so on, we can easily go to different service providers without having them have to re-enter all of their information. This is a dense slide, a lot of words, but these are what make us distinctive. And I just want to pull out 2 or 3 things here. We're obviously patient-led. There are a lot of service providers out there. Brian found one that's coming out of Weill Cornell that has a one-stop shop for sequencing, interpretation, organoids, and so on. It's a very nice service. Brian's very interested in it, but it's always going to be proprietary, and the data that the patient contributes is going to probably be owned and controlled by that organization. So we are patient-led, patient-centered. Again, for me, openness and the notion of sort of a Wikipedia kind of approach is very important. And then the other thing is I would just pull, if I had to pull out another, we're innovative. Whenever we're looking at things, we're trying to lean into new tests, new treatments, new organization forms. We're trying to not follow the industry standard medical industrial complex business models or ways of thinking about how we do things. As I mentioned, we're trying to grow from the current 7 patients to 100. There's some objectives. Basically, it's going to force us to build some infrastructure. We are struggling or working on the notion of organization and business models. I mentioned, since we're innovative, we are trying to figure out, is this a traditional startup that's a for-profit? Is this a not-for-profit? Is it a not-for-profit and a for-profit? Is it a Web3 organization? What is it? How do we get money? How do we get paid? It's all kind of open, and that's part of what we need to do. The basic logic is that if we're currently working completely free and completely as really a virtual entity, but if we scale up, then we need people to do the onboarding and manage the patients. They need to be paid. If they need to be paid, we need to get money. So we're sort of being pushed as we scale into these questions about organization and business model. As I mentioned, we have a few things just to be sort of open about some of the things we need to figure out. I already mentioned money and business model. Physicians and physician engagement are always a challenge. They are very comfortable working in the system as they know it, but finding ways to engage them. Data cleaning is an ongoing issue that many have run into. Privacy, real-world evidence, competing with randomized clinical trials, and finding ways to predict response and resistance. I think I've already covered this. So here are the collaboration partners, and you'll see down there on the prospects, we have quite a number of organizations that we're reaching out to, and individuals we're reaching out to see if they would be interested in joining us. So I think I'll stop there. How did I do for time? That was a little bit over. That was probably closer to 20, 25 minutes. But now is the interactive portion. And fortunately, we're recording this, so I'll be very, very interested in keeping all this in the notes. But as usual, use the hand raising. Let me know if you have questions, comments, suggestions for how we can make this better, how we can grow it, maybe contacts that you can think of that we should be speaking to, etc. Anybody got a hand raise? Anything you want to say? Oh, I see there's some things in the chat here too. Let me check. Oh,
Wait,
one of the slides.
Brad, where is the hand raise?
It's under reactions, and the bar at the bottom, it says reactions, and then it shows raise hand.
Okay. All right.
And Marty, I think you might want to raise your hand, so go ahead.
Well, I just wanted to ask my question.
Okay. Do you have anything to say, Marty? So I should say Marty has been very actively involved in helping build out this pitch deck. And also I'll just say Marty is very strong on the other stakeholders. So I have a big focus, as does he, on patients, but he's also good at making sure that the other stakeholders' perspectives are represented and what they might get. Marty?
Yeah, I just might say that what we're talking about here is a natural evolution of what Cancer Commons has been doing for decades. We've been doing similar initiatives in specific cancers, brain cancer and pancreatic cancer, to be specific, with a desire to grow in two ways. One is to build this out to cover basically all cancers, and to be able to specifically exploit the economies of scale and the opportunities for cross-learning that come from doing that. And so I think that I don't know, Brad, whether in your mind at the moment you're starting in prostate cancer and want to broaden it to others, but I think everyone agrees that when a cancer gets sufficiently advanced, it doesn't behave in the way that a traditional organ-specific cancer does. And so very quickly, a metastatic cancer needs to be thought of as in the same way that you would think about, for example, a cancer of unknown origin, a pan-cancer approach. And that, in fact, is where there's tremendous opportunities to speed learning from a drug that works in one cancer, for example, to all cancers, to other cancers that might share common mutations. But I'm very interested in building a network of networks where this might be a network, and while Cornell might have their own network, learn from each other. And the key is to do this in a patient-centric way, because if you get to the point where if you recognize that every patient's advanced cancer is going to have evolved through many mutations, that's going to make it unique, maybe unique on the planet. And that this cancer has got to be treated with a combination of therapies, both because even an individual's cancer is heterogeneous. There's no way that you can do this in a traditional trial. I would say that the potential combinations exceed the number of patients in the universe. If you just think about the combinatorics, there's like, thousands of drugs that are available, and what's the right way to combine them. And that's just the combinatorics. It says nothing about what Brad talked about with the mode of administration, the process of administration. You give these drugs together as a cocktail or in some sequence. So what's the dosing? What's the order? What's the timing? There's no way you can do this in trials. The only way you could possibly do it is, first of all, to set up a system that continuously learns from every patient. And that's what we're trying to do here. And secondly, to be able to do this in a way where we're not just observing what the patients are doing, but we're sort of looking down with a God's eye view, trying to be a command and control layer that sees what's working, what's not, and try to get more people into the things that are working, or even to be able to plan prospective experiments that just look like they need to be run because the experts are disagreeing this versus that. Well, let's run the experiment. No one is doing that today. And so this is really an opportunity. And trying to figure out, I mean, this audience has many, brings many sources of expertise and discipline to the table. So when Brad and I are struggling with what's the right organization and business model, we're wide open for input. So with that, I'm going to stop talking and start listening.
Thank you, Marty. Jeff, you have your hand up first.
Yeah, I think this sort of goes without saying too, but you list all the organizations you're partnering with, but I think it'd be good to list the academic medical institutions too. If you think of like, you've been working a lot with Pete Kane and Fereshta and the team at Stanford, and we've got Sayed's here, I think, from Rutgers, and certainly we've had Tony Latai from Dana-Farber. So I think better understanding the linkage to academic medical centers of excellence that in an area. They're not a firm like Cancer Commons or XCures, and you know they have other relationships. But I think
it's a great point, Jeff. But you know the interesting thing is that we don't have relationships with academic institutions. We have relationships with very smart academics, and that's a key difference because what we're doing is an anathema to an organization that makes its money off of clinical trials.
well, I guess I still think that doesn't mean that you're sort of in bed with them. You still have relations with them. And the reason I say institutions is because you want it to be based on more than a one-on-one person. You know, there may be, that person could leave that institution and go somewhere else.
I absolutely agree that aspirationally, I'd love to do that. I'm just saying we do not at this time, and that's not for want of trying, have relationships. I've had my wrist slapped. And more seriously, the investigators have had their wrists slapped. Why are you working with these guys?
Yeah. Well, anyway, I think we need to be sensitive. We are. I mean, if you look at Brad's speakers, they've often been from a leading academic medical.
No. Again, we work with the best people in the world, and many of them are academics.
Yeah.
Just go try to talk to their institution about getting a formal relationship. It's not easy.
True.
Yeah, that's the way I've thought about it. It's also every one of the patients is working with their institution and their clinician. And so we have relationships through them as well. And I started putting all those on the slide and it got very cluttered very fast. I think though, your point is well taken. What we're trying to get is the brand halo from those highly respected organizations. And we are in conversation with those people. And I would agree with Marty, the way that we do that is, so we've got someone like Sumit Subudi, who's at MD Anderson, or Raina McKay is available and she's at UCSD, those kinds of things. So we access those institutions through the individuals, but they're participating as individuals. And that's kind of because we are kind of a rogue. We're looking for the mavericks. We're looking for the iconoclasts. We're looking for the people going outside the standard of care and willing to take risks, prescribe things off label and that. So
let me be more specific about where an example of where the rubber meets the road on this issue. Number one is if you try to get the institutions to share data, as opposed to get specific patients in those institutions to give you a HIPAA release to share their data, right? One is easy and the other is virtually impossible. And then another example of this is I've tried to get the tumor boards at the different institutions to share their discussions with each other. Very, very hard. It's not impossible. There we've had a few institutions that have said, our tumor boards are siloed and we would like to learn what our peers are recommending because we could learn from that. But most of the time, take a hike.
And that comes back to the name Cancer Commons. One of the nice things about that brand is the Commons name and the idea that it's, as Marty said, a registry of registries, or you could say it's like a data clearinghouse or a network of networks. And then again, aspirationally, that's the way we're looking at it. It's an underlying theme is learning, and it's collective global learning and trying to be as open as possible by going cross-institutional. So again, you know, Memorial Sloan Kettering is awesome. MD Anderson is awesome. Dana-Farber is awesome. UCSF is awesome. And we're trying to see if we can collaborate across those institutions, which is often hard. Saeed, how are you?
Yeah, thank you. Okay, let me share just one simple screen if it's
Sure.
okay. Let's see.
For those of you who don't know Saeed, he's our expert at data and public data in particular, and sort of learning things that are publicly available in data sets.
Yeah, one thing here is the whole idea of your presentation was really to find answering question or finding something for a need, right? That's the
Exactly.
whole idea.
Yep.
And the first thing we need to do is search. It means we do search, maybe somebody else has that answer. And this is normal, right? This is what we do. I can give you one example. You might not believe it. I was talking to the team at the UK Biobank, which it's a big project, multi-billion-dollar project, and they have the clinical data, lab data, omics data, images. And I told them, do you know about the Geo database or Array Express, which is also in the Europe? Which is these two data sets, they have close to 1 million experiments in these two databases. And they didn't know that. And to me, I said, okay, this is something really. Then the first thing we need have an infrastructure, which we or some collaborator here, maybe the crowd sourcing this idea, to do the search, to see if we can find the answer for that question or need, then put it in the database. We need a QA database, because otherwise we just get the answer and say it and forget it. If there is no answer, then we need to do research. That's the root of research. It means after search, we don't have a data result answer, and we do the research. And now this research might be somebody else doing the research, is in the middle of research, or we can suggest we'll have a website, because we cannot do it by ourselves. But we can be some sort of the platform. We say, okay, this is a question we had. We couldn't find the answer. Can somebody spend? And many researchers, they love to have the work on the new idea and write the papers. Then that's about the experiment, and it goes back to our QA database. Then to me, we should focus on what we need, and then focus and talk about the infrastructure for those needs. As I said, the key here is we have a question and we want to find the answer for it.
So, Syed, I love the slide. This is precisely what we're setting up the infrastructure to do. I would say precisely. The one thing I would add is that, and including making a place where someone who has questions can post them, and maybe someone will either has the answer or will want to try the experiment. But the point I want to make is that there are many, many people who have invested a lot of money in big data bases and big data projects. And I certainly think that, it's helpful if you have data, you may find the answer. But the dimensionality of the space we're talking about, where you're talking about all the combinatorics and the timing and the dosing and all those things, right, will make it most likely that it's going to be very hard to find the answer to most of the questions people are going to have. And and people don't realize this, because the optimal treatments have probably not been tried anywhere. And so the answer is there's zero data on them. And I don't think the world really recognizes that the opportunity is where you say, run the experiment in a prospective way to get the answer that you want. And that's really the key. And that's different than what the industry is doing, which is investing a lot of money in big projects like Flatiron, CancerLink, ...
Yeah, the biggest issue I see in many of this research, so I said last 10 years, my focus was in this field. And they start with even some question. Another problem on top of it is they don't have the criteria, the success criteria. Say, you find some biomarkers, then what? Okay. Even after they find the answer, they don't know about the deployment, the use of that experiments, research they do. But at the same time, this is what we can do. It means otherwise, let's say, for example, a patient comes to this site and he has a question. We cannot give them 30 minutes presentation about what we are doing on this matter. He wants answer. That's all he wants. And now answer might come from the search from the same type of the patient. If that patient uses that drug X, yeah, I believe there are many prostate cancer patients which they are using drug X. Now I am a new patient and I want to know if drug X is better than Y. What's the best thing? We have it in the machine learning. Similarity function, right? We try to find a function to find the similar cases. This is what we can do with the help of our patients. We need to find a good match. Somebody which is one step ahead of myself as a patient, and that one step can help me to see, oh, that patient said, I got a good result, or say, it didn't work for me. Then finding the match, being a matchmaker is what we can do it. Then we can add on top of it. I have no doubt which there are huge amount of data everywhere, but they are not organized. They are not based on the question. They just put the data together, created a database. That doesn't help. When we answer a question, I really like that decision-making process, which we had at I think, I don't remember who presented.
Michael Liebman.
Yeah, that's great because each node in that decision-making process is a question. Should I go this path or this path? To answer this question, again, first, similar cases. Try to have a database which we can bring all these cases together and try to find a good match for it. And then on top of it, there is a public data. On top of it, there is a experiments in action. This is what we need to start to create a platform to control the flow of the data. Otherwise, it's going to be a very difficult job.
So Syed, if this is something that you are interested in academically working on.
Yeah, first of all, I'm not with Rutgers anymore. There is a long story, but right now my focus is on my own startup company, Biota, and yes, as I say, I love to work.
I would love to talk to you, regardless of where you are. And so, Brad, if you would connect us.
Yeah. Yeah, he's in Toronto. He's another one of those nice Canadians. So yes, thank you for sharing that. If you wouldn't mind, Syed, if you would email me the slide you just shared, and I'll put it in the notes so we can capture it there. Okay.
It's on the web.
Richard.
I can share the link.
Okay, good. Richard, you're up next.
This is a really great discussion with lots of forks and depth. I just have some reflections. I'm not sure I can give them in any coherent order, but I'll do my best. I think,
Richard, let me just preface this by saying that Richard, for those of you who don't know him, is an MIT alum, sort of very tightly connected with MIT, and is also an angel investor, has got a mass angels investor community that he works with. Is that a fair characterization or add to it, just so we,
Well, the only unfair thing is it would be unfair to MIT to say I'm an MIT alum, although I did teach there for a number of years, but I was not an alum of MIT.
Okay, all right.
But you know, I mean, I think that the search, I think even the notion of sort of the optimal treatment, and you know, we don't know the optimal treatment. Well, you know, of course that's true, but you know, the optimal is certainly the enemy of the good. I mean, the optimal treatment is a drug you take with no side effects and the cancer is gone. You know, maybe that'll happen someday, but I don't think patients need optimal treatments. They need good enough treatments, and treatments that, you know, are good enough relative to where they are and what their risk profile is. And, you know, if you navigate between the shores of Scylla and Charybdis, you know, it's a really difficult journey because there are risks on both sides. And I think helping patients to understand sort of the risk set, notwithstanding the fact that, you know, there are accepted standards of care, is important. I also sort of want to talk a little bit about the profile and, you know, the institutions, because I think although they're really frustrating, and I was on an IRB at the Dana-Farber for a number of years, and I regularly would, at the IRB, I would say, this is an approved drug in this trial. Is part of the consent form. We should tell the patient that they might be able to get this drug without being randomized. And I thought that it was honestly the ethical thing to do to tell patients that. And routinely, I didn't win one of those battles, but you know, I would routinely say it, and I never won one of those battles. And from the institution's point of view, I get it, because how do you run a clinical trial if you don't have randomization and you screw it up? And they're looking for information. But then there's one other sort of side to this, which is that there is a war going on, and data is totally balkanized. And every institution thinks that data is something that they can control. All the academic institutions seem to sort of want to do that. You know, the Memorial got in a lot of trouble when they tried to monetize their set of data. There are institutions which are agglomerating their data sets so that they can, so everybody's trying to balkanize the data. And it's a very serious set of problems that we deal with on the institutional side. So I think there's got to be, I think that this is going to be a subversive effort, kind of like the homebrew computer club. This is not, you know, in the short run, you go to the institutions and they're going to fall over to partner with you. This is doctor here, doctor there. And if enough patient pull comes through, the homebrew computer club led to Apple Computer and, you know, the microcomputer revolution, but it didn't happen in a day. And I think that that's what this is. It won't happen in a day. It's arduous.
Richard, what's your current affiliation?
I run an angel group, and that's my only affiliation.
And so the interesting question is, I've been fighting the battles that you've described for 2 decades, and actually I'm seeing, you know, thaws in the ice. It's certainly not easy. When I used to bring these things to Dana-Farber or to Stanford at the top of the executive suite, I was told, we can't do that. We're Stanford. We have a reputation to protect. Or at the top of Dana-Farber. I was in the room where the CEO put his fist down and said, we are not sharing data with other institutions in the partner system, which was insane. All I can tell you is that this is a battle that ultimately has to be won and will be won, because patients, we're building here a system which is fundamentally better for patients, and they will vote with their feet. And among other things, you know, we didn't talk about the concept of decentralized trials, but there's no reason a patient should have to go to Boston or Houston or New York to be able to get access to the kinds of therapies that today might only be available in a half dozen places. It just doesn't make any sense. I do have one, you know, really telling question to ask you, which is, as the head of an angel group, would you invest in a company that said, we are committed to trying to break the system by building a system that is fundamentally better for patients?
Well, that wouldn't be the business proposition that I think would garner investment. That might be sort of part of the strategy to do it, but I think, I think there's got to be a path to sort of what is likely to work to be an investable proposition.
No,
And
well, there is. You should, I just, as an example, take a look at what Xcuris has accomplished and what they're trying to do, which, and I'm just, just in terms of the experience of raising the funding, and Xcuris has raised, I don't know, 17 million or a significant amount of money. And it hasn't been easy. We wanted to walk in and try to get, a big check to build a system that was going to learn from every patient. And I think
is it grant funded or investor funded?
No. Funded by smaller venture funds. The big venture funds that I would have expected to write, tens of millions of dollars of checks, which is what it's going to take to do this, said, this is very interesting. It's what I would want. Would I get cancer? Come back when you've de-risked it. Too risky for big checks. And, that's unfortunate, but the reality.
Yeah, I mean, I think VC is hard with, it's just a reflection. I don't know. I don't have any further truth than anyone else, but, VC is hard when you're talking about things that are sort of unknown quantities, and a very unknown quantity is how you make a social movement. Somehow the internet managed to galvanize people and they invested in the social movement. The opportunity seems so big. In the medical field, people sort of look for targets. They look for, drugs that seem effective. The idea of galvanizing a movement is a little bit harder, I think, for an investor in life science to understand. And so that's the challenge, I would think.
Yeah, well, if you're interested in this topic, I get to Massachusetts if you're there frequently, and I would love to meet up with you.
That'd be great. I'd be delighted to do that. I have this vague idea that we did meet once upon a time, but I would love to do that. That'd be great.
I hang out in Andy Lowe's circle, so if you do that.
I've been to those. I've been to a couple of those.
That may be where we met.
Oh, could be.